Welcome back to the Scoliosis Dialogues, the official podcast of the Scoliosis Research Society. I'm Grant Hogue from Boston Children's Hospital, and I'm your host for this episode where we're going to focus on the award-winning submissions from our recent IMAST meeting. 4 awards are given out annually at the IMAST meeting, and we have representatives from each of the award-winning abstracts. The first will be discussed by Dr. Ferran Pellise, and this is the Whitecloud Award for the Best Clinical Paper. The next is the Whitecloud Award for Best Basic or Translational Paper, and this is going to be discussed by Nan Wu, who's the first author on that innovation. The next is the Innovation Award, which will be discussed by Carl Erik Aubin. And lastly, our award-winning E-Point presentation will be presented by first author Dr. Guilin Chen. So thank you all for being here today. And Ferran, we're going to start with you.
Great. Thanks very much for the invite and for the introduction. I'm Ferran Pellise, as was mentioned by Grant. I'm a spine surgeon based in Barcelona, and I'll be presenting a paper which was conceived and prepared by Susana Núñez Pereira. So here's a summary of what we presented. The goal of our paper was trying to characterize the spectrum of health-related quality of life in surgical idiopathic scoliosis across the lifespan using the SRS-22 questionnaire. And for that purpose, we included in a study all the patients from the ESSG database older than 10 years that had been operated because of idiopathic scoliosis. At the end, we had 761 patients, 85 of them being females, properly distributed in all the decades from 10 years of age up to 80 years of age. So the findings that we got are, to understanding, relevant. So what we could see is that these patients, when they are all operated approximately in all ages with curves of 60 degrees of magnitude. But importantly, during the first 4 decades, the thoracic curves predominate. And after the 4th decade, the lumbar curves then predominate. And when this happens, we also is associated to changes in the sagittal plane alignment. So originally, the curves operated during the first 3 until the 4th decade. They have a normal sagittal alignment, and the patients that we operate after the 4th decade progressively are having a deterioration in the sagittal alignment in terms of increased or positive sagittal balance. So this is clearly showing what happens when degenerative changes appear to be more relevant in this idiopathic scoliosis population. In terms of quality of life, the patients, the domain that is always most impacted is self-image, both in the very young and also in the very adult. There's nothing that deteriorates more self-image than a deformed trunk when you are older. But at the same time, when patients get older, after the 4th decade, pain and function also deteriorate. The most important thing that we found, which is good, is that idiopathic scoliosis had a very sweet spot where complications are very rare, and this is before the age of 30, 35, where complications are below 5%. But after that, complications get growing. So it's a simultaneous thing that happens is as aging and degeneration appears and invades the spine, complications are also clearly increasing to become a very relevant problem when we operate patients in the 7th decade above 60 years with rate of reinterventions which are 30% approximately. The SRS improvement is quite evident always in all the lifespan, and there is a clear improvement of self-image at all ages, and pain is improved and function is improved when it is clearly impaired before surgery. And finally, satisfaction is quite high, 4.5 in the SRS-22 score, all over and homogeneously in all the lifespan. So these are the main findings. And if I had to just provide some take-home message. I would say that clearly this is the first study assessing the health-related quality of life spectrum of surgical idiopathic scoliosis across the lifespan. Clearly, self-image is the most affected health-related quality of life dimension at all ages, not just in young patients. And the lifespan spectrum of surgical idiopathic scoliosis clearly reveals two distinct periods, with a turning point around the fifth decade when degeneration becomes as relevant as the original idiopathic scoliosis. Surgery improves always the health-related quality of life dimensions across the entire lifespan, particularly self-image, but there is a clearly increase of complications as degenerations become more prevalent. This is my summary and take-home message of the paper that we presented at IMAST.
You so much, Ferran. It's so maybe my only follow-up question would be that since you presented this at IMAST, I've already seen multiple surgeons making social media posts leveraging your data to say this is why we should be more aggressive or offer surgery at an earlier point, potentially even before patients are symptomatic. And so how does this data, as well as your clinical experience, kind of base your practice saying, should we make it a point to intervene early, or should we wait until there at least is some symptomatic burden on these patients?
That's the key point, and that's the main and most relevant question. I think that if clearly the curves become a surgical curve, and you have curves above 60 degrees, and there's going to be progression, I think this should be enough probably to operate the patients. Waiting that the patient becomes older and have symptoms, kind of pain or loss of function, will just make the surgery later when the patient is probably weaker, more fragile, with more degeneration. And we know that the treatment paradigm we have right now, which is fusing patients, is perfectly working when you are young, but the same idea is not working as well when you get older. And it's not working as well because it's not well tolerated due to the rate of complications. So I think this is what I would, and that would be my answer to your question,
Thank you so much for presenting this. We look forward to more work from your team in the future. Next up, we have Nan Wu, who's going to be presenting for his Whitecloud Award-winning paper for Best Basic or Translational Submission.
Thank you. Thank you very much for giving me the opportunity to share with our manuscript, which got the Best Basic and Translational Award during the IMAST meeting at 2026. My name is Nan Wu. I'm practicing at Peking Uni Medical College Hospital. I am a spine surgeon. I do both peds and adults and mostly deformity. So in the paper, we actually hypothesized that integrating deep phenotyping with the next generation sequencing data can significantly enhance the genetic diagnosis of scoliosis by covering the very subtle and disease-specific and familial traits that is often missed by standardized evaluation for scoliosis patients clinically. So we actually conducted a retrospective study of scoliosis patient review at our center. We try to assess how deep phenotyping can influence the diagnostic outcomes when combined with the next generation sequencing data. So our goal is to identify critical factors that demonstrate the impact of phenotypic details on precise medical care for the scoliosis patients. So we actually retrospectively analyzed the medical record over 6 individuals with scoliosis who underwent a genetic analysis, exome sequencing or whole genome sequencing. We also analyzed the deep phenotyping data that was actually conducted by reviewing medical history, physical examinations, imaging, and family histories. So we showed that there are actually 9 key aspects that highlight the importance of deep phenotyping in scoliosis patient care. So we actually subgroup this into 2 subtypes. That is the the subtype 1 is the high resolution diagnostic phenotyping, including the specific phenotypes, minor indications, and beyond the common phenotypes, quantitative phenotyping and mosaic findings that hasn't been kind of clinically recognized in the traditional or normal evaluation for scoliosis patients. And the second subtype is the familial phenotype, prenatal phenotyping, and dynamic phenotyping, and dual molecular diagnosis. So our findings actually underscore that only genetic study, although powerful, often falls short without parallel phenotyping, deep phenotyping. So detailed clinical assessments, including the subtle, familial, prenatal, and evolving traits, significantly kind of enhance the diagnostic yield for scoliosis patients. So this comprehensive approach actually not only guides the molecular testing, but also refines the clinical management strategies and will ultimately improving the patient outcomes in scoliosis and other kind of spine deformity patients. Thank you.
Excellent. So this is my favorite type of translational medicine because you are really kind of straddling the line between new science and next generation sequencing, but you're also really reinforcing that history and physical examination are still the building blocks for diagnosis, even in modern medicine. And so my question is that even though this was a retrospective study, for me going forward prospectively, when I'm in clinic on Monday and I'm seeing a patient for first evaluation, what are the specific, 2 or 3 physical exam maneuvers or phenotypes that I should be looking for now because of this data?
Oh, thank you very much. So actually, we have integrated this deep phenotyping procedure into our clinical practice in taking care of the scoliosis patients. For example, we need to evaluate not only the spine deformity, but also evaluate whether there are heart problems, kidney problems, and other problems around the body, in other systemic organs. On the other hand, we use not only the kind of imaging data, but also the molecular data. So basically, we published that around 55% of the patients with congenital scoliosis who were operated on have comorbidities, and they can be intraspinal anomalies and cardiac problems, and also other musculoskeletal anomalies. So in summary, I think we not only see X-rays images, but also we see the human beings, which is the whole picture of the disease. And we just evaluate all the systemic deformities around the whole body of every patient. Thank you.
Nan, this is a picture of medicine at its best. Thank you for showing us this. Next up, we have our Innovation Award winner. This is Dr. Karl-Erik-Aubin, who is the first author on the SRS-Lenke-Aubin 3D classification. And so, Karl-Erik, welcome once again to the podcast, and we're delighted to hear you speak. And I think you're on mute.
Okay. Okay, sorry. Thank you very much, Dr. Hogue, for the introduction, and thank you very much to the SRS for the invitation. I'm very grateful for the opportunity to discuss this work on the podcast and to share the collaborative effort behind this project presented at IMAST. So my name is Karl-Erik-Aubin. I'm a professor of biomechanical engineering at Polytechnique Montréal, and I'm a researcher and special advisor on innovation at Saint-Justine University Hospital Center. Executive and Scientific Director of the TransMedTech Institute, and most importantly here, co-chair of the SRS 3D Classification Task Force, together with Dr. Larry Lenke. So I'm a biomechanical engineer by training, and for most of my career, more than 3 decades now, my research has focused on understanding scoliosis as a true three-dimensional deformity, including imaging, biomechanics, physics-based treatment simulation, and classification. And this project reflects many years of work aimed at bridging advanced 3D understanding with something that remains clinically practical and usable. So I would practically like to acknowledge Dr. Larry Lenke and all task force members, as well as my research team and longstanding collaborators from multiple international centers. So the SRS-Lenke-Aubin 3D classification, which was presented at IMAST, this initiative really is motivated by a fairly simple observation. So although scoliosis is inherently a 3D deformity, we still mainly describe it clinically using two-dimensional radiographic measures. Even the Lenke classification, which has been tremendously used and tremendously valuable for over 2 decades, remain fundamentally based on coronal radiographs with selected sagittal modifiers. But in practice, we often see patients with similar Cobb angles and similar Lenke patterns who behave very differently in the transverse plane with torsional deformity. So the objective of the SRS-Lenke-Aubin 3D classification was not to replace Lenke, but to extend it in a pragmatic and clinically relevant way by adding a limited number of transverse plane descriptors. So we really kept this, we tried to keep the most simple as possible. We selected only 2 complementary descriptors for each curve. So the apical vertebral rotation, the first one, which captures local vertebral torsion at a significant level where it is typically maximum, and the orientation of the regional plane of deformity, or ORPD, which captures the regional 3-dimensional orientation of the curve relative to the sagittal plane. So one descriptor is local at the vertebral level, while the other is regional at the curve level. And together, they characterize the transverse phenotype of the deformity. So when we evaluated this descriptor, we then evaluated these descriptors in a cohort of 381 AIS surgical cases with 3-dimensional reconstructions using correlation and multivariate analysis. So what we observed a wide distribution of ORPD and AVR combinations, which confirmed the system's ability to capture diverse deformity patterns. So the 2 descriptors were independent in the proximal and main thoracic regions, but correlated in the thoracolumbar region. So, and when compared with Cobb angles, ORPD and AVR were only weakly to moderately associated in thoracic regions, while stronger coupling was observed in the lumbar regions. But most importantly, similar Cobb angles could still correspond to very different transverse plane deformities. In other words, 2 patients with the same Cobb angles could exhibit very different 3-dimensional phenotypes. So we also observed region-specific behavior. So thoracic kyphosis is influence ORPD in the thoracic spine, whereas in the lumbar region, we found that lumbar lordosis did not explain thoracolumbar transverse orientation to the same extent. So this highlights distinct 3D deformation mechanisms across spinal regions. Another important finding was that even if we found a significant association between Lenke's traditional modifiers and their respective ORPD counterparts, the multivariate analysis conducted showed that more than half of the transverse deformity remained unexplained by conventional 2D parameters. This then reveals important 3D patterns that are not captured by standard radiographs, which effectively extend the Lenke classification into the transverse plane. So in other words, we're not replacing Lenke, we're just adding and complementing it in 3D. So, and I think ultimately the innovation was to achieve it with a balance of meaningful 3D characterization indices and something which could be clinically useful in practice. So if I have to summarize what should be retained from this study, I would say there are probably two main take-home messages. So first, patients with similar 2D radiographic deformities may actually have very different torsional transverse plane deformities. So we are likely missing important information if we rely only on conventional radiographs and Cobb angles. And second, it is possible to integrate clinically meaningful 3D information into practical classification framework without making the system overly complex. So thank you for this opportunity to present this work again.
That's excellent. Thank you, Carl Eric. I know that the social media team, as well as our podcast team, have really had you working overtime in the last 6 months, asking you to help us roll this out and really be kind of the mouthpiece for it. You have done an incredible job of taking something very complex and simplifying it in ways that we can all understand. And so I thank you for that. And so my question, though, would be, could you tell us a little bit about the development process of the technology needed to create this classification system and how you are working to get it into the hands of SRS members?
Okay, so it's a complex question, because when we started this effort, the objective was that it's not the first attempt to develop two-dimensional classification system. So we have worked in this area for more than 3 decades. And in the past, there were several efforts that didn't succeeded because it was either too complex or the accessibility to three-dimensional information was not possible in the real clinical settings. And also communication was complex because there are many different Scoliosis deformity is complex, and using many different descriptors may make it complex to use in practice. So the 3D classification task force decided early in the process to try to select a limited number of descriptors and try to relate them to what could be actionable in practice. So, for instance, the apical vertebral rotation. So each vertebra has a different rotation, but the maximum is at the apex. So by taking only this one is a way to simplify this. And basically, when correcting the spine, we used to derotate the vertebrae to realign them in the sagittal plane. So we try to select in this descriptors that are related to actionable components surgically. Same for the ORPD. We are not just translating the curve in the coronal in the sagittal plane, but also restoring the curve. So the idea was also to reflect regional deformities in a way that could be translated into actionable surgical correction techniques. I'm not sure I fully address all the questions, but also, yes, the other one, I'm sorry, I just remember now. So the other aspect was to make it available to the members. So based on work done in my lab, we have developed technologies that enable to have access to 3D information with any X-ray system. So basically, the technology we develop will enable it to make it automatic. So basically, we enter the X-ray and we'll have the classification.
Excellent. Thank you, Carl Eric. And we're moving on. Last but certainly not least, we have our award-winning ePoint presentation. And this is Guilin Chen presenting on their project. Thank you so much for joining us today.
Okay, thank you very much for having me on this broadcast, and thanks for the introduction. I'm Guilin Chen. I'm now a 5-year PhD student and going to begin my clinical training as a spine surgeon this year in the Department of Orthopedic Surgery at Peking Yulian Medical College Hospital in Beijing, China. And I'm also very fortunate to work under the supervision of Professor Nan Wu. He has guided my clinical and academic development in the spine deformity research, and this study was conducted as part of our team's broader effort to improve scoliosis management. And also, I'd like to acknowledge our DISCO study group, which get a very supportable work of our study. This title of our award-winning study is Improving Early Scoliosis Detection with a Low-Dose Mobile Imaging and Automated Measurement Platform. It's a cross-sectional screening study. The central question we wanted to address was very practical. How can we move from identifying children at risk to actually completing diagnostic evaluation in a timely, scalable, and no-dose way? And for our study, the school screening has been used for decades to identify adolescents who may have spinal deformity at an early stage. In theory, this is very attractive because AIS is a condition where early detection can influence surveillance, the brace treatment, and the referral decision. However, in real-world screening program, the major problem is often not the physical screening itself. The problem is what happens after the children screening positive. In many settings, students who are suspected to have scoliosis need to be referred to a hospital or imaging center for standing full spine radiographs. That process can be delayed, inconvenient for families, inefficient for large-scale public health problems. As a result, a small portion of the screening positive students may never complete diagnostic imaging. So our study focused on closing this gap between screening positivity and confirmed diagnosis. We designed a centralized on-site scoliosis diagnostic workflow. After the initial screening at school, the students who met referral criteria could complete the diagnostic evaluation on-site, use the mobile low-dose full spine imaging system integrated with an AI-based automatic cup angle measurements module. This allows us to support same-visit screening, imaging, measurement, and referral decision-making. The main comparison was the performance of the traditional referral-based pathway versus the new on-site diagnostic workflow. In the traditional pathway, a screen-positive student would be advised to complete radiographic evaluation later, usually at a hospital. In our new pathway, the imaging and AI-assisted measurement will move directly into the school-based screening setting. The most important result was the referral to diagnosis rate improved dramatically. In the traditional pathway, only 86% of the individuals complete the referral progress. And in our new on-site workflow, 95.3 students complete diagnostic evaluation. So this is the key finding of our study. By changing the workflow, not simply by improving the screening test, we improved the conversion from the suspected scoliosis to complete diagnosis. So this study is about an integrated clinical workflow, screening, and low-dose imaging, automated measurements, and referral decision, all happening in the screening setting. So for the take-home message, we can say that in this study, we move the diagnostic confirmation closer to the point of screening by bridging the no-dose imaging and AI-assist cup angle measurements to the school site. And what happens, what comes to next in the patient management? So this study mainly addressed the first gap, how to make sure students who screen positive can complete diagnostic confirmation quickly. But after diagnosis, there's still a long management pathways. Patient need surveillance, bracing, rapid imaging, education, and longer follow-up. So the next important step is to build a longitudinal cohort based on this screening program. This will allow us to answer a more fundamental question. Does early scoliosis screening actually translate into long-term clinical benefits of those population? So at the same time, our next goal is also to combine this screening and imaging platform with large language model and multimodal AI. We hope to build a patient-centered management system that can integrate screening data, image findings, curve angle measurements, clinical information, and longitudinal follow-up outcomes. So ultimately, our goal is to extend this work from early detection to full cycle scoliosis care. Yeah, that's our study. Thank you again for having me, Liz. Yeah.
Well, and thank you so much for sharing with us. I think everyone who's listening to the podcast is excited to know that you're starting your clinical training and that you're going to continue working in the world of spine surgery. And I have no doubt that your future is incredibly bright, particularly with a mentor like Nan Wu. You have shown a stunning optimization in your screening pipeline for childhood scoliosis. I don't know that I've seen a study that's shown a difference going from 15%, kind of a level of efficiency, up to 95%. And so I think this is amazing. When you look to translate this nationally, or as a global society, or even looking at this at the global level, who do you see owning this process? Is this a decentralized service that's run by school systems or public health departments? Or do you think this would work best if it were run by major pediatric medical centers that are deploying mobile units as a hub and spoke model?
Yeah, this is a very important question. For our real practice, we also made this a problem. So in our practice, we are hospital based. We have every center in like a province to conduct the screening process and and then translate those patients who confirm the scoliosis on site into their hospital to finish the follow-ups like brace, like exercise or surgery. So for the nationwide, we actually have a center in our hospital and have many sub center in every district that conduct the screening and conduct the follow-ups of the positives. Yeah.
Excellent. I'd like to congratulate everyone on the podcast today on your awards at the IMAST meeting. I want to make sure everyone who's listening knows that we have our annual meeting upcoming this fall in Australia. So get your abstracts in because we're coming up on the dates. Otherwise, have a great day. And we hope to see you all back on the podcast soon.